can answer any questions. We've listened to everything, and I do
It
want
was
to.
my bad. I said update, but I think what you have on the agenda here is a discussion of the decision matrix.
Yes, and tomorrow is our normal update, because originally, Mr. Chair, the 16th was the hearing date.
Yep.
Okay.
And a bad
What-
choice of words by me.
What I wanted to just go over for our section, and I first want to say, also echo that there was a lot of time put into that recommendation, and I appreciate what they did. And what I've tried to do here is give the task force from our team, I call this a comparison matrix, because you have been presented with a number of recommendations, and I know Senator Hendren talks about the decisions being made, and you're going to be making a lot of decisions even going into the next year. But there are certain things that you have to make by law, and there are things that you should make to give the department the direction it needs to move forward. Director Seelig, I think, would agree with me on this. They're doing everything they can, but there is somewhat paralysis right now in a number of these areas, and time is important, because it's not just the savings, it's the program efficiencies that you want. So it's important to make those decisions. So what I tried to do is to give you an idea as you go through the next couple days, and we'll help you through it, is to look at the different recommendations. If you take out the very first attachment, and it would say, the top would say, Arkansas Health Reform Task Force recommendations, traditional Medicaid care management structure matrix. It's got 15 different points. And where we are different than what Representative Gray and your team have come up with.
Let me just try and tell everybody what they're looking at, because I know it's late and our eyes can tend to glaze over. But what John has done here is to try to take all of these disparate recommendations and ideas against one of the main things that we're going to make a decision on, which is the cost savings on the basic Medicaid program. And what he's tried to do here is lay them out in such a way that we can see versus the population, versus the management program, and whose recommendation is it. So he's going to walk through the specifics of that now, but this matrix for this major element of our decision-making really lays it out in one page, and so it's a very helpful matrix just as we get ready to go through this thing.
So I think Senator Chesterfield mentioned about the decision, how are we going to do that, and what we tried to do is anticipate that question. So there have been a lot of recommendations that you all have been given, and we did even up to last night I was working on this, because Diamond Care was sent to us a couple days back, and Representative Gray had sent us originally Arkansas Works, because in that last update we gave you our thoughts on what some of the savings could be. So what we've done is we also looked at what the governor had recommended in some of his talks and just on his presentation to the task force. I also have sent this to Mr. Martin, John Martin, so he could share with the governor, so that we could also make any modifications. And this is a draft, and I kept it that way so that we can make the changes that you want to make. We could add to this as well. But this first one is really the 15 top numbered items. Is your traditional Medicaid, all the recommendations. Now, there could be another recommendation that comes up, but the ASO type model recommendation that was just articulated is no different in our minds, in our recommendation, than the health home PCMH model. So, and I can explain to you why we feel that way as a group. So it's very similar. And when Representative Gray says, and Representative Boyd, that they're following door number one, the PCMH model, I want to clarify a few things for you, because I think it's so important. These are, if you go back to what Senator Hendren just said earlier about trying to go to the global programmatic structure, this is really one of the global decisions I think you all need to make in the traditional program. So we've done that, and then we've done the same thing for the Healthcare Independence Program, which is the next couple slides you'll see. There's one that'll say in the box, because I wanted to separate them, because I still wanted to give you the out-of-the-box matrix. So you've got that, and then there's this whole host of other recommendations that have come up during the discussions, and it could be that some of them are going to get into the minutia, but the bottom line here is there may be one member of the task force that really wants to talk about that item. it's important just to have you all decide how you want to structure this, but what I wanted to try to do is to give you some structure. And I think this gives you some structure, and we can also add another column if there are other recommendations. But the one thing I do want to say about the PCMH model, Health Home, and Mr. Hanley came up and spoke on behalf of AFMC. I want to make sure that you all understand where we're coming from in terms of our recommendation. It does include risk. We have said that from the very beginning, that in order for you to really make a dent and try to do what you need to do to help people, to be able to remove folks from the wait list, to be able to have some additional savings, you're going to have to move the high-cost beneficiary program into a risk-based model. When Representative Gray talks about care management being different than managed care, we don't see it that way in our practice. It's all about managing the care of that patient. So who's going to do that? Is it going to be a health home model with primary care based as the risk-based entity, or is it going to be a capitated managed care insurance company, the risk-based entity? And we told you there's about 41 states in the country that are here. We just sent you that Oklahoma recently made the decision to go full risk-based, including their long-term care program, DD, and behavioral health. There are some states, Connecticut does the ASO model that the team here was presenting. Okay? So, but there are different components, and it's important that you understand them. Our risk-based model in PCMH Health Home, and Representative Gray, the first time I did hear her say, though, that there was risk. I think she used for the primary care 1 to 2%. I think it was in one of the slides. So it does have risk. So that is getting closer to our model. But our model's risk is much greater. And there's rewards, too. There's upside. And we looked at all the states that had similar models. So if you look at our recommendation, where we came up with about $700 million in savings if you move to a risk-based PCMH model, Health Home. Our $700 million, if you look at the high-cost population, you're talking about, and I just ran a real rough sketch, you have $989 million long-term care program costs. 5% of that $989 million is $49 million. You have $723 million program costs in DD. 5% is about $36 million. You have $464 million program costs on behavioral health. 5% is about $230 million. You add those up, that's about $108 million. Then you look at the medical costs. All the medical costs for that population, about $700 million. And if you add a 5% to that, that's about $35 million. Now you add 5% to that program in terms of risk, at risk. That is about $143 million. If they don't meet the baseline quality, whoever the entity is or entities, quality, care, savings, $143 million, and our $700 million savings was about $160 million a year. So it's very close. And we could go through it, and Stephen did a lot of the analysis. But I want you to know the components there are, big effort is the long-term care rebalancing from the nursing home into the community. Big effort. And then you can see the DD and the behavioral health. So who do you want to manage that, and who can deliver on those savings? And the other thing I want you to know, because nobody's mentioned it today, and we did talk to the insurance company, and it'll be in your mail if Phil didn't send it to you already, is their letter on the managed care tax. One thing that wasn't mentioned was that moving to a capitated managed care gets you a premium tax. And it gets you a premium tax. So if you take, like for example, you carve out nursing home, that's about $35 million you're not going to get on a premium tax, and matched with federal funds.
John,
that's
let's just talk about this premium tax again. For the slow learner group, I said, give me an example. Let's use automobiles. We all understand those. So I said, if I opened a BMW dealership in Fayetteville and started selling BMW, something that never sold before, what happens to the state? Well, every time you sell a BMW, you pay the state sales tax. So in insurance, we don't call it a sales tax. We have a different name for it. It's called a premium tax. So if we take our current insurance market, which includes our health insurance, our life insurance, all the other insurance that we have, this would essentially be standing up a new insurance market. And so since we have a sales tax on insurance called a premium tax, we now as a state would be getting tax revenue from that process. So that's what this premium tax animal is that comes with managed care. And John, obviously tweak what I said wrong.
Well, I mean, it's just a great analogy, but I want to make sure you understand that. You don't get that premium tax with an ASO model. But the ASO model in our PCMH Health Home Model number 1, door 1, that ASO model that is in Diamond Care, that is the AFMC company, whether it's AFMC or anyone else, that model is in Connecticut, and that model can work if it has the type of risk-based contracting that we're talking about. But managed care also has that premium tax component, and managed care also has a track record of generating higher savings across the country off a baseline. So that's what we use to generate our hybrid model is around 1.6, I believe $1.6 billion, which doesn't take into account the premium tax. And the premium tax is another $347 million. So if you, for example, were to decide, you know what, we'll move down the road of managed care capitated plan for behavioral health and development disability, and we'll carve out the nursing home, your premium tax would be deducted by $35+ million on average. That's just general from a 2.5% tax. Now, what I did was recently, California has been told by CMS that their premium tax is at issue, and because it's not levied across the board, it's not uniform, and it only applies to Medicaid. So the governor in California now is looking at a major couple billion dollar hole in the budget because of that issue. So I asked on your behalf the insurance department to look at the letter from CMS as well as the California situation, and they indicated that a more legal interpretation would have to come from DFA, but in their opinion, your tax does not run afoul because your premium tax is across the board, and it applies to all health care plans. So I think you're comfortable there, and we feel comfortable as well. So those are some major differences, Mr. Chair.
If you're at a break-in point, we'll take some questions. It looks like Senator Chesterfield, you're recognized for a question.
Thank you, Mr. Chair, and good to see you guys back.
Same to you.
Did you visit with the individuals who were at the table before to determine whether or not they're in agreement with your assessment of what their plan does as opposed to what you say it does?
I mean, we've spoken, Representative Gray and I spoke on the phone, and we were given the plan about a month ago when it was called Arkansas Works, so we've started to look at it through detail. And I've had a number of discussions with various members of the team, yes. But again, my only concern is there are some differences, and what I tried to do is outline them for you so you'll see the differences here. There are differences in terms of higher costs, because wellness program and the entire Medicaid program is not something we recommended. That's going to have some cost. Now, down the road, there may be savings, but I'm not sure if you're going to get those savings. We recommended a wellness program, by the way, in the alternative, the healthcare independence program. Why? Because what Senator Hendren talked about in terms of a sting. Because we felt if you didn't do that, which you should do and get to the care coordination route, that you're going to have to pay a premium. And that was in the box type thinking.
Well, John, on page 4, at the top of the page, independent assessment.
Yes.
Is the reason you have nothing in those boxes because neither one of you has that?
No, the independent assessment is in both our plan and their plan.
Okay, well, you didn't have
So
your boxes there, so I was just
I apologize.
curious as to what that meant.
Yeah.
And
There are some that I'm going to have to go back and look over.
in having dealt with these issues before, where you have the diversity of opinion that we have on this committee, what has been the process? Because at some point in time, we're going to have to get to process. What has been the process that has gotten individuals to consensus in the past? Because we have a report from you, and I have a great deal of respect for you, and we have one from the Diamond Group, and I have a great deal of respect for the individuals that have presented that to us. How then do we mesh those two pieces of acknowledgement on my part into something that is workable and that the governor can use in seeking waivers that he can then bring back to the legislature?
It's a great question.
I finally got one that was great.
And I want you to know, too, that you'll have tomorrow acronym explanation here, so
Okay.
I've already started that.
All right.
Here, there are a number of different approaches here. I can tell you an example in my home state. When we negotiated waivers, the general court passed a law that said the fiscal committee would have to approve the final waiver. So the waiver would be negotiated by the executive negotiates all waivers. And then the executive would come and present to the fiscal committee, which could be like the task force, but that was in legislation. There are other states that have laws that require the full body legislative approval. So there are different ways of doing it, and there are other states that just allow the executive and come and report to the legislature on what you're doing. With regard to this particular issue here, I think it's important, though, that we talked about this the last meeting. The timing is really critical to at least begin those negotiations, and then I think that the governor would come back to your committee with what the discussions have entailed, but recommendations are what the legislation calls for. So by the end of December of this year, you would have to issue your recommendations on the alternative to the healthcare independence program. You do not have to, and Senator Hendren, correct me if I'm wrong, because I know you looked recently at this, you do not have to issue full recommendations on traditional Medicaid. My concern is that from our group here, it's important that you make at least some of these high-level global decisions, because the program needs to begin making the movement in the direction to attain savings and improve efficiency. Does that help?
To some extent, what did they do in your fiscal committee, which would be the closest thing to this committee? Did they just duke it out over a couple of hours until they came to consensus on what needed to be there and what did not need to be there? Is that basically how that worked?
Yes.
Okay,
Yes.
so we're good at duking it out. All right. Thank you very much.
Representative Boyd, you recognize for a question.
Thank you, Mr. Chair. And as you like to say, slow learner group over here. So help me understand this premium tax just a little bit more. We've talked about it. We've had discussion on it. But so the government is currently not paying premiums on traditional Medicaid, correct? Yes?
Yes.
Okay. So if we hire managed care, then each person is, quote, insured with a policy, and we pay a tax. So really, the government, so that's the managed care companies are gonna throw that in as a cost of doing business. So really, the state government is paying that tax. Is that right? Help me understand what I'm missing in that concept.
Stephen?
So what it affected, that is right. I mean, within the premiums that are paid to the managed care organizations is included an amount that then effectively gets paid back to the state. Now, when it's paid to the managed care organization, it's matched with the federal dollars, because it is at the normal Medicaid matching rate. When it comes back as the tax, it is general revenue. So in effect, what it does is it slightly increases the effective federal matching rate that y'all receive for that pool of money that flows through the managed care organizations.
So it's a net increase.
Representative Farrar, you recognize for a question.
I think Representative Boyd just asked my question. So we pay, the state will pay a premium tax to the managed care company for each, that the managed care company gives the money back to the state sends it to the federal government puts a match on it, and we get the difference.
Well,
Is that where you're saying? I guess is that where your savings is coming from? Or you're saying the managed care is going to give us savings of that, but it's actually money that the federal government is match.
when we pay it to, or when the state pays it to the managed care organizations, it is matched.
Right.
But that same amount comes back as state general revenue through their premium tax.
For the premium tax. Then it's and then the federal government does the match, the FMAP, the 70.
Yeah, the match happens on the front
traditional
end.
Medicaid would be 70%. So are you, in your numbers, and I can't find it, and I'm sorry, I can't find it, are you taking is that the match that you're getting on there, or is that the total?
That is the total in those estimates.
That's the total, so you're not actually doing the 70% of that?
Those don't, in the traditional, or in the managed care cost savings estimates that we did, we have not netted out the
So what in the net?
state piece. I'm
So
sorry?
how much could you tell me, so would the number be 70% of that number?
Yes.
Okay, so it's not that big of a savings, it's not 1.2 billion?
Not quite, yeah.
So it'll be 70% of what, so it'll be $800 million?
Yeah.
Let's do the math together. My understanding is the total tax is 347 million times 0.7. I don't have a calculator in front of me, but that's
145 million?
okay, 245 million, and you've entered in 300 million, so instead of 1.9 billion, the overall number is 1.846 billion. Is that right? So if we net that tax out for double counting the Arkansas money, the savings drops from 1.9 billion to 1.85 billion, about 50 million less. Is that correct?
I'll trust your math on
Okay.
that.
So we're doing a, we're
Yeah,
doing a-
I just want to make sure you capture, that's a very valid point. If we're paying money and then just collecting it to ourselves, that's not true savings, but the difference of money that wasn't ours before is. But I just want to make sure that we understand, so instead of 1.9 compared to 700 million, it's now 1.85 billion compared to 700 million. That's what I want to make sure that
Yeah,
we're staying
but
on
I-
track with.
Yes, but I want to be, clear in Representative Ferrer's question. The savings from the program baseline reduction is based on other state models, which we modeled, is 700 million for PCMH, health homes, high cost, versus 1.6 billion for managed care capitated, full high cost. Those are real numbers in terms of savings. The additional tax is added on to the 1.6 billion. I want to make sure.
So, but I guess what I'm hearing from, we're gonna have a tax increase to pay for the managed care company, and we're gonna get 90%, or so much of that money back. So it's a tax increase that we're gonna get paid back on.
You have a tax already, so it would apply to them, just like it applies to Ambetter, QualChoice, and,
Oh, you're right, but on the
Be like if we got the Toyota plan in here, we'd have a tax increase because we'd have new income, and the income we collected on those workers would add to our tax. So overall taxes in Arkansas would go up, but it's through a new market is the driver.
right. But I want to make sure Representative
But we
Farrar,
don't have as of right now, we don't have a premium tax on traditional Medicaid.
you have a premium tax on health plans, and it doesn't apply traditional Medicaid. It's all health plans that have to file for an insurance license across the board. So it's not separated. Where California got in trouble, Representative Farrar, is they did it just on the Medicaid.
Right, and now, okay, so we're not talking about increasing another Medicaid tax? Okay, thank you.
It's not a new tax.
All right, that's all the questions we have right now. John, you can continue.
And so there was a couple other, I just want to make sure, and then the rebalancings are really important when you begin your discussions as part of that chunk of savings. The restructuring of RSPMI and making sure behavioral health. Tomorrow, we're going to give you an update. Representative Gray had asked us to do some additional data analysis on behavioral health claims, so it's going to be really important that you see some of those claims as well, the analysis. So I think that having a management entity of those can work. And other states have done this. Some states, very small number, have done the ASO model, predominantly in the behavioral health area, not for the whole high-cost population. But it can be done, and we would be able to work with you to make sure that your recommendations are met in the contracting. And the final question is on the RFP that Representative Hammer had mentioned. There was actually two CMS-related questions. It may be that CMS is going to require a competitive bid on a contract that large. I have had pushback before on issues with CMS, making sure there's a competitive contract. That could happen. Secondly, the other CMS issue is on actuarial rates. Managed care, capitated plans have to, by law, assure that their rates are actuarially sound, or the state has to assure that they're actuarially sound. So the actuarially soundness requirement under federal law applies to both dental and capitated managed care plan in any, across the board. And that, though, you can try to waive that requirement, but nobody has had that waiver happen yet. And again, we'll provide a little more update tomorrow on just some of the general issues that you've asked for in the last meeting. Senator Rice, we've got some information for you on that nursing home per capita income. So there's a lot of little things, but we'll get through it as quickly as possible, knowing you need to make some
Okay,
decisions.
so John, I just want to, again, just because I'm trying to make sure I understand what you've got here. You've got 4 columns. Your 2 proposals that you gave us on October 7th, that we've all been studying diligently for 2.5 months, right? And then we've got 2 additional columns on here, Diamond Care and the governor's recommendation. And Diamond Care is essentially similar to your recommendation on PCMH, with the exception that it does not have the shared risk component, which your PCMH has. And the governor's recommendation is essentially similar to your TSG hybrid proposal, with the exception that he has a PCMH carve-out for the nursing homes. Is that
Yeah,
an
yes.
assessment of that?
I don't want to
Is it-
speak for the governor, but John Martin is reviewing the sheet to make it clear, so by tomorrow, you should all definitely know when the
Okay.
governor speaks.
All right, Representative Ferguson, you're recognized for a question.
Yes, I have a question. I thought at one time I was told that we reimburse Arkansas Blue Cross Blue Shield part of the premium tax based on employing people in the state. Is that right? And how does that figure into the formula you're talking about for what we would gain through the premium tax? Because they are our biggest insurer.
Yeah, I'm not aware, Representative Ferguson. I can check into it, but I don't know. I know that whoever bids on a managed care type contract in any state usually employs state people anyways to work with them and to do a lot of the work. So,
We have some special, I would have to go back and look it up,
Yeah,
but we have some
Excuse
special
me,
contractual.
excuse me, Representative Ferguson, we have, Senator Bledsoe just pointed out to me, we have a representative from Blue Cross Blue Shield.
Okay, perfect.
Max, would you be willing to come up and answer that question?
I'm Max Greenwood with Arkansas Blue Cross and Blue Shield.
You're
Representative-
recognized.
Thank you. Representative Ferguson, if I understand your question, I don't have the specifics, but I do know that there are offsets that all companies have available to them with regard to the number of employees that are employed within the state. So I think that is what you're what you're referring to with regard to offsets with any premium tax that we pay in.
Does that come out of the premium tax then? I'm just unclear how that works. Is it reimbursed from the premium tax? And how much is that?
I don't know. I can check with our accounting department and get back with the committee tomorrow if that would be all right.
Right, yeah, I'm just trying to figure if we're not really keeping all the premium tax, in reality, what's the number he's talking about gonna look like?
Would you like the amount of premium tax that we submitted to the state last year, or?
Yeah, and what the offset is, I mean, I just kinda like to follow that formula.
Well, I believe that the credits occur before we submit the
Okay.
amount to the state. So, I'm sorry, Senator, did you?
Yeah, that would be helpful.
For last year?
Yeah, that would be great, thank you.
And then, Max, when you do that, if you would say, what, if anything, would be different if it was a managed care Medicaid program as opposed to whatever these other taxes are, just in case the way it would be managed is completely different?
I will get that information.
All right, I don't see any more questions. John, were you finished or not?
Well, I just want to make sure, I think Phil sent the letter from the insurance department to all of you, or you will be getting it tomorrow. And so you'll have a letter that the insurance department wrote to us regarding the question on the California potential issue. So I think it answers the question that you just asked.
Okay, and then, so for all of us, you know, this question that John's got there, the governor's recommendations, the governor is going to be here tomorrow morning, and I'm confident he'll share with us, and so we'll be able to cross-check what John's got on his matrix versus what the governor says, and then we'll have our discussion and take our action items and get our updates. So we'll see everybody in the morning.
Thank you.
9 o'clock is the time tomorrow. Thank you very much. Without objection, we're adjourned.